Thank you. Thank you very much indeed for asking me to come and speak about MIGS. And when I started 13 years ago, we spent 12 minutes talk about the eye stand, and that's all we had to talk about. Now to talk about MIGS over 12 minutes is rather tricky because, as you know, the variety that we have is huge, and the data that we have beginning to come out is also huge. So bear with me. I'm going to rush through some of this, and it'll be a bit of an overview. I work with a lot of companies, so you may not believe anything that I'm going to tell you. And I think that everybody will agree that this is the favorite saying. Our gold standard in glaucoma surgery is trabeculectomy. And personally, I really hate this particular statement. I hate it because the fact that, well, as you know, nowadays, gold is really nothing. You know, a gold level generally doesn't mean a great deal because you know there's a platinum and a platinum plus above. So gold is nothing. But more importantly, when people say gold standard, I struggle to understand which particular standard we're talking about when it comes to trabeculectomy. Which standard are they saying that trab is best? In terms of, is it the lowest IOP they'll achieve? And I give you that. That remains the best operation to get you the lowest IOP. But is it the highest success? And those two things may not be the same thing. Is it the lowest complication we're after when it comes to the best operation? Is it the longest lasting that we need? But is it the best vision that we need to achieve with this operation? Is it the lowest maintenance? And trabeculectomy certainly is not one of them. Is it the cheapest or the most cost-effective operation? Is it the quickest operation there is out there, especially when due to the capacity that we have to deal with? And more importantly, and this is my big bugbears of mine, is it universal results that everybody trabeculectomy give you the best outcome? And you can see these are the criteria nowadays that we focus on, not just the IOP, does it get you down to 10? And I think we've gone past those, and we work very hard to try to find the holy grail in glaucoma surgery, and we clearly haven't got one. And we're constantly on the podium debating about this. And I get asked this all the time. These are all the procedures out there. They're more than this slide shows you. Are these new surgery a complete waste of time, Leon? People ask me that all the time. We have a lot of ab-internal MIGS, which I'll focus on. There are some subconjunctival MIGS, if we have time, we'll touch on. But ultimately, you're going to hear how to do trab step by step later on. And no doubt, I do a lot of trabeculectomy. I think is a very good operation when it's done well. And that's the key. It is an invasive procedure. It takes time to do, and it certainly takes time to learn. The recovery is delayed. Patient can't do certain physical activities for the first few weeks. There are definite potential for complications. I won't for a moment say trabeculectomy is dangerous. I think gone are the days that we bash trabeculectomy. I think it's safe, but there are definite potential for complications. So we still see nowadays that some surgeons are still a little bit too unkeen. So they put people on one too many medication. I am a big supporter for less medication. So unfortunately, I'm not keen on the 2 bottles, 4 medication, 3 drops a day. You know, I think too many people are on too many eye drops. We get their eyes too red, too sunken, and then wait for the disc to cup out a little bit more, wait for the field to go really bad, and then people do it reluctantly, a trabeculectomy, and ended up not quite how they wanted to look. And I think there's a lot of procedures that we can come in before we get to that stage to try to delay the trabeculectomy. And I think it's very important to stress that most of the MIGS we're talking about are not trab replacement. People must get it out of their head that there is no point comparing a stent with a trabeculectomy. That's not what we're here to do. We're here to delay trabeculectomy if at all possible. It's a trab avoider, not a trab replacement. We talked about Schlemm's canal and trabecular meshwork resistance. Some of the new drugs potentially help with those. Unfortunately, some of the new drugs seem to cause awfully a lot of red eye. The eye stand was the very, very first MIGS device. I started it back 13 years ago. It's a little snorkel that we inserted ab-internally. This G1 remains actually one of my favorites when it first came out in terms of the ease of use and in terms of the cost. Since then, it's moved on a little bit, and that may not be to the way that I particularly like, but I really did like the original G1, which started off the MIGS era. And iStent is now moved into an injector, which makes it easier to implant for surgeons. They scale the size down, and I think size does matter. I think the smaller size give you less outflow, which has been shown on benchtop. But it's easier to use, which sells well to the cataract surgeons. You tend to over-implant the injector a little bit because it's small and you can fire it through the meshwork and completely over-bury it. So they now come out with the Inject W, which I think is better. It's got a bigger flange, so you're less likely to over-implant. But take it from me, you can still over-implant this and shoot this right into the canal and completely bury it. So you still have to take care. It's still a small size, 2 little points, and you have to place it at the right place, which to make it effective is harder than it seems. Now, and they understand that they may be coming out with the Infinite, which is 1 injector with 3 stents, and you may just feel that that's taking the concept just a little bit too far. I will talk a lot about the Hydrus because that is the ab-internal device that I believe in. I have no particular financial disclosure with the company, but I've been involved with the research and the usage for quite many years now. It is a bigger device. It's like putting a brown venflon into your vein to give you good access. So ab-internally, we cannulate the canal. It gives you a 3 clock hours dilation, hold it there with an access point, just like the you can see in the video. It's a bit harder to put in, which puts some surgeons off, especially some of the cataract surgeons. Initially, they may be a bit put off when may not be able to get it in. Just like you can't get a brown venflon in every single vein. It is harder to get in, which can be disheartening when you've got an expensive device and you can't get it in the eye. But I think the data is there, and I'll show you. The whole point is that if you can access Schlemm's canal, bypass the meshwork, when I put in the vision blue in the eye, and you can see it flowing straight out to all your collector channels. When you see that on the table, then you know you've connected to collector outflow. At least you've got a chance for the pressure to come down. We can remove the meshwork, and I think this is a Kahoot Jewel blade, a video courtesy of my friend Ziad. You can do it with a bend needle, and I think bend needle technique or the bang technique seems to be very popular in India and South Africa and other country where cost could be a concern. And I don't really see there's a big difference between a Kahoot Jewel blade with a bend needle, really. We are just removing the meshwork and trying to open the Schlemm's canal. You are going to bleed. Whether you like it or not, they are going to bleed. So we almost see the blood reflex as a good sign. Well, I have some reservation. If someone's paying me to go and do a cataract surgery and you combine it with a mixed and reduced medication, they do want to see 6/6 the next day, not hand movement with a hyphema for 2 weeks. So you do have to pick your patient very carefully and they can get some blood reflux later. So you take that concept further. The GAT is very popular amongst my pediatric colleagues. Zinab's a good friend of mine in Turkey. In pediatric congenital glaucoma, I think GAT becomes a first-line therapy. We are ripping the meshwork 360 degrees. This is not a new concept. It's been tried and tested for many, many years. It was almost ignored for a while, come back into fashion. You can do it just with a 6-0 Prolene. You can do it with a fiber optic. It can give you very impressive IOP lowering at the right patient when meshwork disease is the key, like the pigment dispersion, some of the uvitics, some of the JOAC, but they do bleed quite dramatically in some patients too. You have to put up with some hyphema. I love this. This is reasonably new. This is the iTrack Advance. We are ab-internally advancing a fiber optic, but this is now loaded into a injector. So now you just put the injector in and slide, and the fiber optic goes in. You can see the flashing lights going around, and with one single finger slide, I cannulate the Schlemm's canal 360 degrees as you see the fiber optic coming back round into view. If anything, for any trainee watching, it's one of the coolest operations you do because finally you get to cannulate this mythical Schlemm's canal that you know is actually real. And then when you withdraw, then you can then viscodilate your canal with a GV to dilate the canal. And there's some idea that treating 360 degrees of the canal with viscodilation and canaloplasty has been around for quite some time. But the canal is not the only place that MIGS gone to. Suprachoroidal space has always been there for many, many, many years. We've been there, tried it, failed. We've yet to have a successful suprachoroidal device. The last one was the CyPass. I launched the CyPass for outcome in many countries, and then this got withdrawn because of endothelial cell loss. Not because of the device, but because of the device not being placed properly. So this is the iStar. Now we're going around again to suprachoroidal space. This is surgery that I did just a few weeks ago. One of my very first, and this is much harder surgery than I anticipated. We are implanting this sponge into suprachoroidal space, creating quite a cleft. Minimally invasive, probably not. This is quite invasive procedure, but we are trying to make an attempt to tap into suprachoroidal space. You can see the iris manipulation, that can happen and the potential for complications. So mix may not quite be mix, but suprachoroidal device is here. Allergan or AbbVie is now in conjunction working with iStar. Now there's a financial agreement, so potentially if iStar is good enough, it will become a AbbVie Allergan product. Again, it's quite chunky, but the data so far, the IOP data anyway, is looking quite promising. And if you are a laser refractive surgeon, do excuse us for using your excimer laser. This is an excimer laser ab-internal trabeculostomy. So after your phaco, you don't have to do your phaco. We're having an excimer laser will ab-internally create 20 trabecular meshwork window using an excimer laser. And I like the concept because it doesn't bleed so much using a laser to create the window. We're not looking for a huge amount of reduction. Everybody must understand we are at best restoring physiology. So we're going to get you somewhere around about the mid-teens, and that's all you're going to get. So in terms of efficacy, we all kind of know that we all have the similar sort of FDA trial comparing phaco versus phaco mix. With all the devices, with the success, we always find that adding a mix give you around about a sort of increased success. With the Hydrus, it give you almost up to 20% higher chance of achieving a success. Phaco generally in the clinical trial give you 5 millimeters of mercury drop. Adding a device like the Hydrus give you an extra 2.3. So on average, and that's quite a lot. Someone's mentioned the Eagles only give you an extra 1.18 millimeters of mercury. At least the Hydrus give you an extra 2.3. We mentioned post-op IOP spike. Interestingly, on the Hydrus trial that we did, then when you look at the first day phaco, actually IOP spike was less in the group that's had a Hydrus device implanted compared to phaco alone. So it does seem to iron out some of the IOP spike. And that's almost regardless of your pre-op IOP, that the spiker, if you have a Hydrus, you're less likely to spike. So the EGS now talked about mix. They give you a moderate IOP lowering and a reduced medication burden. And I think that is true, and that's all you're going to get. But there's a lot of people on a lot of medication, and reducing medication is not a bad thing. When we ran that Hydrus trial through 5 years, you see that the efficacy remains the same. We're still having a 20 to 30% margin over a phaco alone. But this is the big one, right? Where if you add a Hydrus device to your phaco, you are 3 times less likely to need to have subsequent filtration surgery compared to phaco alone. And that is the big one that we've been after. We still then try to convince people that adding a mixed device to a phaco is worth your while, despite a 3 times reduced risk of needing a subsequent trabeculectomy. So people still argue that TRAB is a proper operation. And I would say that yes, if you've got ischemic heart disease, then a CABG, a coronary artery bypass, is a proper operation. But if you take an aspirin every day, it would reduce your risk. There is no debate about that. So if you add a Hydrus to your phaco, you will reduce your risk of needing trabeculectomy. And there really shouldn't be much debate about that, accepting the fact that adding something to your phaco is worth your while. Thanks to Gus, who did this study. And then when we pull out the visual field data of the Hydrus trial, this is another big result that we've got. If you look at the phaco Hydrus versus phaco alone, if you had a Hydrus put in the phaco, your visual field progression is significantly less compared to cataract surgery alone. This is another big one we'll be after. Does your mix prevent visual field progression? And it does. Cell count is stable over 5 years. And so even Cochrane agrees that certainly for the Hydrus, the data is of moderate certainty, which is pretty high praise for Cochrane. And we think that is a worthwhile thing. And we also think that the Hydrus is more effective over the iStent. So that seems to be the one to go for. So I'm probably going to end on this because of time, that the question really is not about which mix, but it's more about why not. It's not about why to have mix. It's all really about which mix that we should go for. And a lot of the choosing is quite complicated depending on your availability, depending on your technique. But if you look at the science at the moment, then Hydrus is heading above everybody else. The cost continues to be a major concern for me and for everybody else in the world. And I think the reimbursement, I think the cost of device are too high. And I think we have to work to try to get the cost down. And I think we should increase the number of surgeons around. I think certainly in the UK and in Europe, we have a lot of talk about who should be doing this. Should it be the glaucoma people? Should it be the cataract surgery people? I think there's a lot of territorial behavior in terms of who should be doing it. And I think that as far as it's good for the patient, anybody can do it. And I don't really have a big problem, a cataract colleague putting in a device, as long as they're trained to put that in. I think because of interest of time, I'm probably going to end there. I don't know whether there's anybody got any questions regarding these ab internal mix.
Okay, thank you, Leon. That was wonderfully done. And the most, we're really impressed, and the way you covered everything in right the time given to you. We have just started doing these procedures, and the most important thing we have learned is that, and wherever I go to take lectures in my country, I keep telling everybody the future of the surgery, glaucoma surgery, lies in the angle. So it is as simple as that. Because we all know that the trabs have so many complications. Unfortunately, like you rightly pointed out, the cost is a very big factor. And what you didn't actually say, but obviously because it doesn't happen in your country, but with so many of our people do not have those kind of microscopes which are actually required. Because you really need a lot of magnification, and you need a really good microscope to be able to implant those things. The cost is prohibitive at this moment for us, but the future. So I'm telling most of the people, at least buy a gonioscope, tilt the microscope, whatever you have, see the angles. Once you start seeing the angles, yes, the next step would be this, and it will definitely so many times help you not go on to trabeculotomy sooner. Maybe later you'll do it, but yes, so many years may be saved. Thank you very much.